here. So guys, keep communicating in the chat box. I'm looking at the chat box here on my phone, so that we can start communicating and talking. Lag तो बहुत ज़्यादा है, मैं कम से कम ऑलमोस्ट 1 मिनट से बात कर रहा हूँ एंड अभी तक मेरी स्क्रीन पे ये लाइव हुआ नहीं है. So I don't know if it is going live or not. Okay, maybe it is now because an ad is showing. All right, let us. Yes. All right. Okay, so the best way for me to know is if I start seeing the answers to the first question. See, these questions I'm sure you would have already answered PYQs before, but इसके साथ जो approach होता है, how do you approach the question, how do you answer it? There are some tricks and tips that may help you. So let me just remove this first image where I can be very distracting to a lot of students, तो इसको हटा देते हैं. And I put this question in front of you, and once I start getting some answers I will explain. Like again I'm telling you, lag रहेगा, तो कम से कम I think from my understanding 1 minute का lag है. So by the time you write something and by the time I see it and respond, it will be 1 minute, and this will be like a Quentin Tarantino movie. Not Quentin Tarantino movie यार, वो किसने बनाई थी? And also let me know if the audio is fine. I think audio is fine. Yeah. All right, can you guys hear me well? Is the audio fine? And what is your answer to this question? Which of the following best describes Trotter's triad? So palatal palsy, temporoparietal pain, conductive hearing loss. रोबोट इज मैसेजिंग गुड इवनिंग सर. गुड इवनिंग रोबोट. आजकल रोबोट का ज़माना है, डाविंची आ गया है, बहुत सारे सर्जरीज कर रहा है. ENT में भी वी डू रोबोटिक सर्जरीज, स्कल बेस सर्जरीज. सो नाइस टू सी द रोबोट ओवर हियर. ऑलराइट गाइस, व्हाट इज द आंसर? वंस आई स्टार्ट सीइंग सम रिस्पॉन्सेज आई नो कि आप लोग जिंदा हैं, एंड आई विल स्टार्ट एक्सप्लेनिंग. व्हिच ऑफ द फॉलोइंग बेस्ट डिस्क्राइब्स Trotter triad? Okay, let me see over here. Keep this in front of me. तो अगर कोई रिस्पॉन्स आता है तो मैं देख सकता हूँ. Okay, so let me take this one and then next one you can start answering. See guys, Trotter triad. Trotter is a guy who did a lot of work in the nose. The moment Trotter comes, you have to think of something in the nose. The robot has said it is B. But think of this clue. Trotter did most of the work in nose. You must have heard of this method called Trotter's method. Trotter's method is जब नाक से bleeding होती है, when there is epistaxis, you have to pinch your nose and press it for about 8 to 10 minutes, bend forward, and that is called as the Trotter's method to stop bleeding. Trotter ने सिर्फ नाक में दम किया हुआ है, सिर्फ नाक पे काम किया हुआ है. So that is the clue that you have. Now what nasal condition is going to cause palatal palsy, parietotemporal pain, and some sort of hearing loss, yeah, retroorbital pain and diplopia? That is basically what we are trying to decipher over here. Now this is a condition that is seen in nasopharyngeal carcinoma. ठीक है, nasopharyngeal carcinoma. If I'm let's say this is the back of the nose and this is your eustachian tube opening. ठीक है, and here is your fossa of Rosenmuller. Fossa of Rosenmuller is a place where this nasopharyngeal carcinoma will arise from, जो एकदम कोने में है. So when the nasopharyngeal carcinoma is growing, it invades into a space called sinus of Morgagni. उस जमाने में अच्छे नाम नहीं रखते थे, ऐसे कंफ्यूजिंग से Morgagni, Wagner, ऐसे नाम रखते थे, not so cool, Brad and those kind of names. So Morgagni sounds French. इसका एक साइनस था, इसने आइडेंटिफाई किया. साइनस इज अ ब्लाइंड पाउच. ठीक है, फिस्टुला इज ओपन इन बोथ वेज. ये साइनस ऑफ मॉर्गैग्नी इज बिटवीन द स्कल बेस. लेट्स से दिस इज द स्कल बेस एंड यहाँ से जो सुपीरियर कंस्ट्रक्टर मसल आती है, बिटवीन द स्कल बेस एंड द सुपीरियर कंस्ट्रक्टर देयर इज दिस होल स्पेस ओवर हियर, जहाँ से ये यूस्टेशन ट्यूब ऊपर जाता है. So if this is going to invade into the sinus of Morgagni basically has the eustachian tube. It has the two muscles that supply the eustachian tube. It has the tensor veli palatini and levator veli. Tensor and levator दोनों veli palatini है, and there is ascending pharyngeal ascending palatine artery, which is a branch of the facial artery. So when this cancer is going to grow into the sinus of Morgagni and it is going to block the eustachian tube, you will have conductive hearing loss, not sensory neural hearing loss. And because the palatine muscles are involved, you will have palatal palsy or palatal asymmetry, and because of the nerves that are involved in that area, which is also supplied by the trigeminal branch, you will have a lot of temporoparietal neuralgia. So that is how you can approach this question. Trotter matlab nose, and then because of the access to sinus of Morgagni, this is causing palatal palsy and temporoparietal pain, conductive hearing loss. S is saying, sir, I am going to start MBBS journey, but I've always been bad at organic chemistry. Would I be able to understand further subject? Of course, you will be able to understand further subject. You don't have to be good at organic things to understand MBBS. MBBS is very inorganic. इसमें से कुछ लॉजिकल समझ में नहीं आता है, तो आप एकदम आराम से इसको कर जाओगे. अगर ऑर्गेनिक चीज़ें समझ में आती तो शायद मुश्किल होता. Alright guys, next, a child with throat pain has whitish membrane in the tonsillar region which bleeds on scraping. Very straightforward question. There's a whitish membrane in the throat, but when you scrape it there is bleeding. What do you think it is? Acute membranous tonsillitis, candidiasis, diphtheritic tonsillitis या infectious mononucleosis? क्या लगता है आपको? Infectious mononucleosis, also called as the Kissing's disease. Kissing's disease, seen in the youngsters, because when they kiss, the virus causes infectious mononucleosis. But what do you think? Robot is saying C, और कोई है जो आंसर कर रहा है? Success is also saying CC कर दिया मैंने. Very good. It is diphtheritic tonsillitis, so we won't waste time on that. Diphtheria is the only one which has a true membrane. Acute membranous tonsillitis has a pseudo membrane, PSEUDO, spelling ऐसा है कि लिख नहीं सकते. And candidiasis, it is very painful. Yeah, Tech with Alex is saying it is painful that you are kissing someone and then having a membrane. No, I think he's talking about diphtheritic tonsillitis, which is very painful. So they have odinophagia, and that is the correct answer. We won't waste much time on this. All right guys, 7-year-old child presented with epistaxis and bilateral nasal blockage after he fell down on the face. Very common with 7-year-old children who don't listen to their parents. कुछ नहीं करते, इधर उधर कूदते रहते हैं, and they hurt themselves. On examination, there's swelling around the nose. What do you think is the further treatment? So Akash is saying complete septal excision. I think he is answering the last time's question. But what will you do over here? See here, remember, if there is injury to the nose, all these 4 can be indicated. That's why I'm saying that ये लोग जो examiners होते हैं ना, ये एक ऐसा क्लू दिमाग में ये इसमें क्वेश्चन में डालेंगे which is going to tell you the answer. Here they are saying swelling is around the nose. They are not saying swelling is inside the nose, and they are not talking about nasal blockage. If they are not talking about or hinting about nasal blockage or pain or swelling inside the nose, we cannot think of septal hematoma in this particular case. If they are saying around the nose, then it is most likely a nasal fracture. And when it is a nasal fracture, you have to do a wait and watch. And because child presented with epistaxis and bilateral nasal blockage, then we have to think of nasal fracture. If there was no epistaxis, then and pain would have been mentioned, then we could have thought of hematoma. So here I think it would be anterior nasal packing, which would be the first thing that we do to stop the bleeding. Because do not forget, epistaxis is put over here. अगर epistaxis already हो रही है तो incision and drainage किथे डालोगे? So sometimes we think of something and we think that is the answer, but you have to look at some small words that these guys place over here, and with that you will be able to tell what it is. All right guys, patient with ear wax underwent syringing. Wax निकालने के लिए पानी डाल के धोया. During syringing, developed syncopic episodes. Behosh, not because of the good-looking ENT doctor, but because of the bad technique. Stimulation of which of the following nerves is responsible for this? Auriculotemporal nerve, chorda tympani, Arnold's nerve, or Jacobson's nerve? This is a बहुत common question पूछते हैं, because the posterior ear canal is supplied by which of these nerves? Palu is saying B. Success is saying Arnold's nerve. Arnold's, that's why, Arnold was successful, because he knew that इसके साथ ही लोग बेहोश होते हैं. But Shahbaz Ryan, it is not Jacobson's nerve. Jacobson's nerve is in the ear and it is going down the floor. Arnold's nerve hota hai when you are stretching the ear. If you want to try this syncope, take your finger inside and keep shaking it. Put something inside, put an otoscope inside, and you'll start feeling cough. Cough will be the first symptom, parasympathetic. Cough will come, and after the cough, you will have syncope. So generally, when we are doing any ear examination in a patient, if the patient for any reason coughs, because these nerves, they can be very sensitive for some people. The moment the patient coughs, we actually stop, allow the patient to recover. Otherwise, we will need atropine and there will be an emergency. And then afterwards, as a doctor, you will turn into a patient and you will not be unconscious because of a syncope. Cope with that. All right. A patient with CSOM presented with rhinitis test positive and fistula test positive. Bhai, this is a very tricky question. So please read this question very carefully on what the examiner is trying to get out from you. All right. A patient is presented with CSOM. There's chronic suppurative otitis media. Rhinitis is positive. Fistula test is positive. Fistula test means when you are pressing this tragus, you're doing like this, you're seeing nystagmus and vertigo. That means there is a connection between the middle ear and the inner ear, and that's why there is this balance that is happening. Now, here is the most important part of this question. Patient refuses treatment, nahi karega. Came back after 2 months. That means CSOM to rukega nahi, it is going to progress, and there is negative fistula sign. What is the tuning fork test that is expected in this patient? Now, in the same scenario, if we say patient agreed to the treatment, recovered, the fistula closed, then you can have a positive rhinitis test, which means air conduction better than bone conduction. But here, patient's CSOM has progressed, and maybe the cholesteatoma or whatever it is, the disease has blocked the connection to the labyrinth. So that means here you are going to see a true negative rhinitis test, which means bone conduction is better than air conduction, which is seen in any middle ear pathology like CSOM. Okay, so don't get confused with a lot of this. See, false negative rhinitis test is seen in sensory neural, hearing loss when it is severe to profound. When it is severe to profound, the cochlear nerve is not able to get anything. Then there is a false negative where it is actually air conduction is better than bone conduction, but because you cannot hear, it says bone conduction is better than air conduction. Okay, so do not get confused by these hearing tests. They're very, very mathematical and very, very straightforward. The CSOM, a middle ear disease, has progressed and patient has come back after 2 months. Fistula is closed because of the disease. So obviously you are going to have a true negative rhinitis test. Okay, so you will not have a false negative in this case because there's no sensorineural involvement, and you won't have a true positive because patient has not improved kyonki treatment to liya hi nahi. So words are very important. If you read them carefully, otherwise you'll quickly jump into a conclusion and make a mistake. All right. Okay, 6-year-old child. Oh, sorry, not 6-year-old child. Sixth question. A child presents with history of foreign body ingestion. Haliya kuch. It looks like a coin. X-ray picture given below. Where is the possible site of foreign body impaction over here? As you can see, ये एक side profile view है, and you can see these are the lungs and this is the vertebra. So this is a side profile. Now in the side profile, you can see that this foreign body is appearing flat, which means it is most likely in the esophagus. If it was in the trachea, then it would appear circular in the side view, because the trachealis muscle जो पीछे होती है, this is a trachea, the trachealis muscle is soft, so the coin usually will go into this direction, but in the esophagus it will go in the other direction. So here it is impacted in the esophagus. It is a fairly straightforward question, so इस पर time waste नहीं करते. All right, what is battle sign, guys? Battle sign. What is battle sign? So when you are fighting, battle sign मुक्का लगता है तो similar. Battle sign is basically you're having ecchymosis. Ecchymosis in medical complicated words means blackish collection in edema that is there on the mastoid, and that is a sign of injury to the mastoid bone area and the base of skull. Periorbital ecchymosis is a raccoon eye. Raccoon eye. This is also seen in base of skull fracture, but that is called raccoon eye. And battle sign is ecchymosis. Tympanic membrane में blood collection is called hemotympanum. Hemo matlab blood, tympanum. And pitting edema of the mastoid is not battle sign. Pitting edema of the mastoid could be because of infection of the mastoid when there is edema or some other blood vascular issues. Okay, so correct answer is ecchymosis of the mastoid. All right, we have 75 questions, so thoda jaldi jayenge, but if you have any doubts or anything you want me to explain again, you can write in the comment section. और भी अगर आपके पास random question है तो वो भी हम answer करेंगे. All right, what is following is true about little's area? Always circle what you're doing. कभी कभी false, all except. This is how I answer in relationships now. True, all except. Confuse कर दो आदमी को. But here they ask me what is true about little's area. Kesselbach's plexus is present in little's area. This is true. It is present on lateral wall of the nose. No, it is lateral wall of the nose is the turbinates. It is on the medial wall of the nose, which is the septum. So ये answer गलत है. It is present in the posterior part of nasal cavity. No, it is present anteriorly. It's anterior nasal bleeding. All right, and it is a rare site of epistaxis. It's a very common site of epistaxis. So this is the only true question of Kesselbach's plexus. 5 arteries that make 5 arteries. Okay, so what are these arteries? You have anterior and posterior ethmoidal artery. Okay, now एक पुराना जमाने का thought process था where they were saying posterior ethmoidal artery is not a part of the Kesselbach's plexus, but a lot of recent literature is telling that the watershed area of the posterior ethmoidal artery does contribute to Kesselbach's plexus. So as per latest literature, anterior posterior ethmoidal artery both are involved. Then you have the sphenopalatine artery and the greater palatine artery. Both of these palatine are part of maxillary artery. Ethmoidal is part of ophthalmic artery, and there is one superior labial artery which is a branch of the facial artery which comes over here. All right, so all of them are the ones that basically part. So Chandani Keshwani is written correct. Greater palatine, sphenopalatine artery, anterior posterior ethmoidal, superior labial artery. So सोच लो ना, सी septum इधर है, what are the structures around it? Of course from the lip इधर से facial artery branch दे देगा, maxilla से 2 palatine branch इधर से दे देगा, ophthalmic पीछे से दे देगा, anterior posterior ethmoidal. It's all location and geography, but नाम ऐसे रख दिए यार कि याद नहीं होते, sphenopalatine, ethmoidal. That's the only thing. हमारे if we had the control on the name, we would have kept it simple. होठों के ऊपर वाली नस, simple, नाक के साइड वाली नस, चीक बोन वाली गुजी वाली नस, आराम से कर सकते थे. ये क्या है भाई? Alright, Monarch is asking anyone from AIMS Bhubaneswar. वाह, यहाँ networking चल रही है, चलने दो. A patient presented with pulsatile tinnitus. Now pulsatile tinnitus, the tinnitus is going up and down. On examination, there is reddish mass behind the tympanic membrane. What is the possible diagnosis? Guys, this question may look simple, but isme examiners confuse a lot, okay? And I will tell you why. We all know that it is glomus tumor here, okay? But glomus tumor has 2 types. There is glomus tympanicum and there is glomus jugulare. All right. Now, अगर यही question में ये दोनों option डाल देते, then you would have been confused. Okay. So if it is glomus tympanicum or glomus jugulare is the one which has the sunrise settings, the rising sun. Somebody said setting sun क्यों नहीं है, तो setting sun से related वो सारी चीजें हैं. Chandani Keshwani, not Schwartz sign. Okay, Schwartz sign is associated with otosclerosis. यहाँ पर you see flamingo pink eardrum, and that flamingo pink eardrum is because of increased vascularity on the promontory behind. क्योंकि otosclerosis is a misnomer. Actually otospongiosis होता है, वो bone spongy bone होके बाद में sclerose होता है. So that's why Schwartz sign is not going to be seen in this thing. You're going to see the rising sun or the setting sun. So if you look at the eardrum like this, all right, so this is the handle of malleus, this is the lateral process, this is the cone of light. So you will see like this, okay, if it is glomus jugulaire. If it is glomus tympanicum, you will just see something over here. All right, so do know that there are these two different things that you can get easily confused with. Right, a 14-year-old boy presents with a reddish nasal mass, profuse epistaxis and proptosis. Okay, so they have given you a lot of example. All right, so proptosis, एक तो 14-year-old boy बोलते ही you're going to think of juvenile nasopharyngeal angiofibroma. Let me tell you, it is not exclusive in males. Sometimes the examiner can also say it's a 14-year-old female, and it may be correct because nowhere it says it is 100% only in males. It is only almost exclusive in males, but it is present in females, and when it is present in females, the most common spread is maxillary sinus. So if juvenile nasopharyngeal angiofibroma is present in females, most common site is maxillary sinus is where it spreads to. Okay, so 14-year-old male, reddish nasal mass, juvenile nasopharyngeal angiofibroma. Inverted papilloma, you will not have proptosis and all profuse epistaxis. Okay, inverted papilloma is a very localized condition. This is a nasopharyngeal condition that grows a lot. So profuse bleeding. Why there is a lot of bleeding in juvenile nasopharyngeal angiofibroma? Because their blood vessels don't have muscular and elastic fibers. ये नहीं होता है. That's why it cannot control the bleeding. That's why the profuse bleeding is more. And proptosis is when it is going behind the eyes and you have a frog face appearance. Frog face appearance. Okay, so all of these are clues that it is juvenile nasopharyngeal angiofibroma. That's why in सारे questions को तुम बोलो जाना DNA. Right? Okay. Now a newborn is cyanosed at birth. Cyanosed means bluish discoloration, not able to get oxygen at birth. But when the child is crying, child is fine. So why is the crying improving the airflow, and when the child is not crying, it is causing cyanosis? This is a very common or classical feature of choanal atresia. Choanal atresia में क्या होता है? Back of the nose, between the nose, when the nose ends and the nasopharyngeal part starts, there is a membrane or a bone. So if I draw the side view of the nose, and this is the nasopharynx, this is where the nose ends, there will be a membranous wall over here. So there is no air going from the nose into the airway. But when the child cries, the airway opens and the cyanosis reverses, because babies are obligation. They are obligatory nose breathers. उनको बोलो मुंह से सांस लो, उनको समझ में नहीं आता है. They are just born. So that's why you have to figure out a way to keep the mouth open. So some people have taken a nipple and put a hole there, and you put that nipple inside the mouth, and the child is suckling, the airway opens. Or that is a modification of the oropharyngeal airway, because if you give anything, oxygen prongs by nose nahi chalega, CPAP BiPAP or by nose nahi chalega. Only oropharyngeal airway is going to work, because it is choanal atresia. This is called cyclical cyanosis. Okay, so this was an applied question, indirect, based on the symptoms. Okay, now 6-year-old child, history of mouth breathing, high arch palate, looks like Darshil Safari from Tare Zameen Par, failure to thrive and hearing loss, difficulty in breathing on and off. What is the best management plan? Best is the word. Remember, every time, sometimes they will say which is the next step, which is the most important, which is the, here they're asking which is the best, which is going to give the best option of treatment, and it is adenoids with grommet insertion. Adenoids are very common between the age of 6 to 13 years, and these grow and block the eustachian tube. They cause hearing problem. They cause a lot of crowding of the teeth. They actually impact the growth and fusion of the facial bones, and that's why they cause this kind of face, which is called as the adenoid facies, not feces, facies. So zyada fark hai. All right, look wise. All right, but so that's why you have to remove the adenoids also and grommet incision. But if they say which is the primary treatment, if they use the word primary approach of treatment is always going to be some sort of myringotomy or grommet insertion. But if they are saying best, then you want to do both. That's why focus on the word that is being asked there, and that will give you the best clue. All right. Now, diphtheria patient develops right vocal fold palsy. Fold is equal to cord. Some people call it fold, some people call it cord. They are not two different structures. This is a scheme only meant to confuse the innocent. They're the meaning the same thing. Okay, what will be the management? So diphtheria patient or a child has developed right vocal cord palsy. What will you do? You will let me see what you say for this. Okay, so we will wait for this. What do you think is the answer? Omkar says we will do gel foam injection. Okay, what are some other people saying over here? Chandani Keshwani saying gel foam injection too. All right, guys, look, here's the logic. Okay, as a clinician, this vocal cord palsy is because of a bacterial infection. Okay, it's an infection. It's caused by Corynebacterium diphtheria. So C. diphtheria has caused an infection. All right. So now jab infection hai, you know, if you treat the infection, any edema or any effect of the infection will reverse. It is nothing here indicating that it is a permanent vocal cord palsy for which you need to give any gel foam injection or medialization or any fat injection. Okay, and this itself gives you the clue. Agar gel foam hai, fat hai, and thyroplasty 1 hai, all three are medialization. They all mean the same thing. So why will they give you three options which are saying the same thing? The answer is wait and watch. Wait for your medication to work. Diphtheria antitoxin आपने दिया है, antibiotics आपने दिया है. Let the edema and infection settle down. The vocal cord palsy will most likely reverse. You just only have to do symptomatic management. Thyroplasty 1 is medialization. Medialization means if there is a palsy, you bring it closer. Gel foam, fat, this is all medialization. Thyroplasty 2 is lateralization. Dur karo, make it far. It has come in the middle, make it far. 3 is shortening, especially in sex change operation, female to male. You want to make a nice bass baritone voice, do it like this. Or from male to female, you want to do lengthening. Then your basal voice will become longer because of the length. The tension बढ़ जाता है. Short होता है तो tension कम हो जाता है, right? That's why that is the main thing. Okay, so application, think about how to approach the answer rather than guessing. You will be able to crack these questions. All right, what is this instrument over here? I know it is blurry, all right, but if you look at the options, what is evisceration, enucleation? These are all ophthalmic words. Syringing and probing, isse to karoge nahi. All right, yeah, so Chandani is right. For puberphonia also you do these surgeries where you want a more masculine voice, but the male has female voice, like a child's voice. It has not been pubertized. All right, so here, okay, this is a Kerrison's punch, and this Kerrison's punch is used to punch out the in dacrocystorhinostomy, the agar nasi cells and the cells that are there around it, so that you can remove the blockage from the nasolacrimal duct. Okay, and so that's why it's a Kerrison's punch, and this punch is used to punch something out. Your eye instruments usually will not be so big. I am not sure, but I think so. And syringing and probing you don't do with a device like this. Okay, but pardon the lack of clarity of the image. Okay. We won't spend much time on that. Yeah, it's a bone punch. Jafar is correct. It's a bone punch. It punches out from the lateral wall of the nose, the area to open up the lacrimal duct sac area. Identify the structure marked in the image below. And here, just to highlight, they are talking about a structure that looks like this. All right, and this, what do you guys think it is? It is right. This is the tongue over here. This is the vallicular base of tongue, and then there is something coming like this where this is marked. And Bhavna is correct. It is epiglottis. That's why when the epiglottis becomes swollen in a condition called epiglottitis, on the lateral view X-ray, you will see the thumbs up sign. All right, thumbs up sign, which you most likely would have got by drinking thumbs up, which was stored in the fridge, and then you got a viral infection. How ironic life can be. Okay, so but very straightforward. इस पर time waste नहीं करेंगे. We have another 60 more questions to go. Mucormycosis will affect more in pregnancy, diabetic ketoacidosis, childhood, or leukemia. So mucormycosis came into limelight because of courtesy COVID, and COVID did something that allows mucormycosis to grow. Now mucormycosis के बारे में you have to know that this is a fungal infection, mucormycosis, and this mucor basically it feeds on free iron, and if it has a lot of sugar. Generally we don't have a lot of free iron sugar, and it needs an acidic environment. What COVID was doing is COVID was increasing the amount of free iron, serum free iron, ferritin, sugar, and making the environment acidic. And in diabetic ketoacidosis you have sugar and acid. You have acidosis and you have diabetes. So that's why in diabetic ketoacidosis you will get mucormycosis is slightly higher. It is a commensal. It is already there in your nose. Okay, so the moment this system changes, you can develop diabetic ketoacidosis, and it is extremely invasive, can cause blindness, and is a very dangerous disease. Everything looks black because of all the necrosis it is causing. Now it is an aseptate hyphae when you look in the microscope, and here I know a lot of students are getting confused with the word aseptate. उनको लगता है septate is branching. Septate is not branching. Septate is, if this is the hyphae, hyphae is a branch. Okay, septates are like this. It has these kind of lines inside it. These kind of lines are seen in aspergillosis. Okay, in aspergillosis it will be seen. Yeah, acute angle of the hyphae is one of the things, but in mucor you will not see any hyphae. That is what it means, aseptate hyphae. But when there is a branch, there you might see a septate happening. So you will see one or two random septate, but most of the time it will be aseptate. So suppose if they give you an image and they just show you something with dots but no lines, that is mucormycosis and aseptate. Okay, so this is where the examiner is trying to get a little bit of your fundamental microbiology out, right? So let's move to the next question. Identify the sign shown in the image below. And my principal also used to ask this question to my parents after I used to come back with my marks card. They used to ask, identify the sign given in the image below, which I had forged of my parents. Of wonderful marks. But here sign basically means what is a clinical sign, and here basically we are seeing that this is Holman-Miller sign. Holmer-Millen sign, you are right. Shayad Maqsood is right. 100 Shubham Sharma is right. Wow, stop. All right, you're correct. It is the anterior bowing. You see this bowing is anterior towards the face, towards the tip of the nose, anterior bowing, which means the nasopharyngeal, the juvenile nasopharyngeal angiofibroma. The juvenile nasopharyngeal angiofibroma has pushed everything forward and made the back wall of the maxillary sinus bow. That is called as a Holman-Miller sign. Okay, and that is seen in juvenile nasopharyngeal angiofibroma. Maxillary sinusitis, you will not see this. In maxillary sinusitis, you will basically see इस तरह का, you will see opaqueness. You won't see black color. The sinus will be filled with this kind of grayish white color. Phelps sinus in carpal tunnel syndrome. If you ask someone to flex their this thing, and don't make your muscles dance like this, but if you keep it like this for 60 seconds, you start feeling tingling and numbness. That is because of that. Liar sign is seen when the thoracic outlet syndrome is there. All the nerves and vessels coming from the thoracic outlet, if they are blocked, So sometimes you can have hand pain and hand weakness. It's got nothing to do, these two don't have anything to do with ENT. Okay, so they just had to put some signs, so they put it there. Common Miller sign is correct, and I think most of you know that. An infant presented with inspiratory stridor. What is inspiratory stridor? While taking the breath inside, there is an abnormal noise. Inspiratory stridor sounds like this. Okay. Expiratory stridor is stridor during expiration. And biphasic stridor is stridor in both times. All right. Now here you have to understand that this is something like a Bernoulli's phenomenon. Wherever the direction of the air is there, if it is pulling a structure downward, you are getting stridor. That's why whenever it is above the vocal cords, so anything above the vocal cords which is supraglottic, you will see inspiratory stridor, because supraglottic, above the glottis, when the air is going into the vocal cords, it is pulling everything down, causing a stridor only during inspiration. But when you are releasing the air, it is pushing it away, so you are not seeing a stridor there. So supraglottic stridor will give you inspiratory stridor, and a subglottic will give you expiratory, and if it is glottic, it will give you biphasic. All right, very, very simple physics to understand this. Now laryngoscopy, you're seeing omega shaped epiglottis. Now इधर लोग ऐसे क्यों confuse हो जाएंगे? Because you can think, see, the epiglottis is also omega shaped when you look from top. But when the epiglottis falls down, it looks like a proper omega, and the omega sign is basically seen in laryngomalacia, which means the supraglottic or the larynx is very, very soft. Just with the air breathing itself, it is blocking the opening, and that's why when a child is trying to breathe, is struggling to take that air inside, and that is shown by inspiratory stridor, like okay. So I hope that is a little more clear and you can understand that. You are right, Jainu, SK and KK and Subham Sharma, Maqsood, Shaur Patel, Bhavna Sharma, Chandani, all of you guys have told this correct. If trumpet is given the laryngocele, that is correct. Trumpet, anything that is going to increase pressure, and if it comes out from the side, it could also be somebody doing a Valsalva maneuver or somebody playing any airway instrument where the pressure is going to increase. They basically mean laryngocele. Okay, so that is correct. Now, a 45-year-old male patient, history of acne rosacea. Acne rose की तरह लगने वाला ये जो acne है, is presenting with the following symptoms. What is the most likely diagnosis? This acne rosacea, when it happens of the nose, the swelling of all the sebaceous glands in this area, it is called rhinophyma. Rhinophyma. Nobody really knows why we get rhinophyma. Carcinoma of the nose will not look like this. Carcinoma of the nose will look like some blackish, irregular tissue like this. Rhinosporiodosis is known for strawberry nose. Strawberry nose. You'll see an image with reddish, fleshy, black dots. Strawberry nose. Rhinosporiodosis is caused by Rhinosporidium seaberi. And whenever there's going to be a question on rhinosporiodosis, they will say that the person took bath in a pond or some unclean water, which is the source of Rhinosporidium seaberi, which is a parasite. It is a parasitic infection. Rhinosporidium seaberi causing strawberry nose. Rhinoscleroma is woody nose, and rhinoscleroma is caused by Klebsiella rhinoscleromatis, and Klebsiella is a bacteria, and this causes a woody shiny nose, and rhinoscleroma spreads in overcrowding, close contact, breathing over each other's faces. So when you have these questions, the examiner is forced to give you direct clues, because there is no history taking over here. So without the clues, you will not be able to answer it. So with some of these clues, जैसे पानी में swimming in water, pond comes, you know there's pointing towards rhinosporiodosis. Woody nose, overcrowded environment, rhinoscleroma. And here they've given an image, rhinophyma. Okay, it's fairly straightforward. आप आराम से इसको decipher कर सकते हैं. Patient with road traffic accident presented with mixed blood discharge producing a pattern of blotting paper showing over here. So you can see there are multiple layers. Something is red, something is little lighter, something is little lighter. This is called as the halo sign. Okay, some people also call it the target sign. Some people say double target, दो तीन target दिख रहा है, because you see here also, double target sign. Okay, so this is very straightforward of CSF being present, CSF rhinorrhea plus blood. Blood will agglutinate very quickly on this starch paper, and the water will be there. What is the difference between exam of NEET PG and next exam? At the moment, the difference between NEET PG and next exam asked by Supriya is the spelling and the nature of the exam and what it gives you. First, NEET PG was only for PG entrance. NEET PG bolte, my daughter is screaming. You can hear, dekh rahe ho. NEET PG was first a PG entrance. Next exam is going to be both a PG entrance as well as your degree exam. It's going to be a qualifying exam as well. Okay, so that is the difference. In terms of the questions, it's going to be MCQs only. But only thing is, in next ENT को थोड़ा वेटेज मिलेगा, क्योंकि you guys will be like, no भाई ENT में कुछ नहीं आता है यार, 5 क्वेश्चन आते हैं, 10 क्वेश्चन आता है. In next 60 मार्क्स का क्वेश्चन अपुन से आएगा, तो अपुन का वजूद थोड़ा बढ़ गेला है. Okay, so Chandani is saying beta 2 transference specific, which is also correct. Now teardrop sign is a sign of acute otitis media. You have the tegment tympani. Tegment tympani is the roof of the middle ear. Sometimes this pus inside the middle ear causes some amount of erosion and causes the tegment to have this teardrop appearance. So this teardrop sign is one of the signs in acute otitis media. Schwartz sign is otosclerosis, like I told you, sclerosis. It's flamingo pink eardrum because of the promontory which is behind. Otospongiosis हो रहा है, lot of neovascularization, so pink लग रहा है. Crescent sign is seen in CSOM. Crescent sign is also seen in some sort of fungal maxillary sinusitis. Depends upon what clue is being given. Crescent basically means the annulus which is there of the tympanic membrane, the erosion of the annulus can cause a crescent sign. How to improve image-based questions, Vatsal Kumar is asking. You have to see a lot of clinical videos. We are also trying to bring it in PW MedEd, a lot of clinical images and video-based, questions for you that you can, improve it. Teardrop sign is also on the floor of the orbit fracture. That is also correct. Teardrop sign is also in the floor of the orbit. There are multiple ways. Depends on how you look at it, right? So that is there. Identify the test in which cheek is being done and suddenly somebody can breathe better, and it opens this valve. So this test is used to determine most significant site of nasal obstruction. The nasal valve is this triangular part, the first point of entry, narrowest part of your nasal cavity is the Lyman nasi. Lyman nasi. Chandani is saying Schwartz sign will be seen in ASOM in stage of suppuration. No, Schwartz sign is flamingo pink eardrum seen in otosclerosis because of excessive vascularization of the promontory because of otospongiotic activity. A lot of medical terms, but basically क्या होता है, the bone around the foot plate of the stapes is becoming red because of a lot of new blood vessels. So your drum looks flamingo pink. That is the Schwartz sign. Okay, you will see lighthouse sign in stage of ASOM suppuration. Okay, rest of you are correct. Shahid, Shubham, Jafar, Bhavna, Shahu and Chandani, you're all correct. It is a Cottel's maneuver. Cottel's maneuver, you're basically widening this Lyman nasi, which is the narrowest triangular part lined by the septum on one side, anterior part of the turbinate and floor of the nose cavity. And if you think you have some amount of deviated nasal septum or turbinate hypertrophy, you can, if you breathe better like this, then you will respond well to a surgery. Hemlick's maneuver is something stuck in the throat and you are going behind the person and you are applying pressure below the diaphragm to make them expel the air out. Epley's maneuver is for posterior semicircular canal otolith, where you have something called as BPPV, benign proximal positional vertigo. You make the positions to put that otolith back. Simon's maneuver is also for posterior semicircular canal Here you make a patient lie down one side, then you lie down quickly. It's more rapid, and it also moves the otolith and triggers the nystagmus. Okay, so that is the Simon's maneuver and Hemlick's maneuver and all of that. All right, now a patient presented with bilateral neck swelling. Okay, this is a very tricky question, guys. Think about this. Neck swelling is bilateral, temporoparietal neuralgia is there, and unilateral hearing loss. This is also Trotter's triad. Okay, we already have a question on this. This is an indirect way of asking Trotter's triad, but you may be getting confused. Why is the bilateral neck swelling there? Because in nasopharyngeal carcinoma, one of the commonest presentation is lymphadenopathy, cervical lymphadenopathy, juvenile nasopharyngeal angiofibroma, hypopharyngeal angiofibroma, laryngeal carcinoma. It is the lymphadenopathy will not be there bilateral until it is very advanced. But in nasopharyngeal carcinoma, because it is there in the nasopharynx, the supply of lymphatic drainage can be there on both sides. So this is again, like I told you, sinus of Morgagni involvement. What are the structures that go through the sinus of Morgagni? Eustachian tube, the two muscles that supply the eustachian tube, levator veli palatini, tensor veli palatini, and the ascending palatine artery or the vessels that accompany it. That's why you will have conductive hearing loss. Okay, don't get confused. Some people thought in the beginning sensorineural hearing loss hai. It is conductive hearing loss because of eustachian tube blockage. But eustachian tube blockage can also cause negative pressure damage to the inner ear. So eventually they can develop sensorineural hearing loss also. That's why medicine is complicated. All right. A child presented with nasal discharge, nasal obstruction, and recurrent upper respiratory tract infection. So, naak se pani band, URTI. On examination, mouth breathing, high arch palate, not able to thrive, सारे ज़मीन पर, दर्शिल सफारी. This is adenoid hypertrophy. Tonsil में ऐसा नहीं होगा, lingual tonsil में भी ऐसा नहीं होगा. Bisolt's abscess is when you have this mastoid, abscess over here, mastoiditis, and the complication, the pus drains into the sternocleidomastoid area. So pus draining into sternocleidomastoid area. If it goes into the posterior digastric muscle, then it is called Sitelli's abscess. All right. So this is very straightforward. We won't spend much time on this. We have many questions. We'll spend time on ones which require more thinking. This is straightforward adenoid hypertrophy. Okay. 3-year-old child having inspiratory stridor and cough. Like I said, inspiratory stridor means supraglottic. Supraglottic inspiratory stridor. Glottic biphasic, and subglottic is expiratory stridor. Clear? So, yeah, you're right, Shahu Patil. It is a complication of CSOM, Bisolt's abscess formation. Now, 3-year-old child is having inspiratory stridor and cough. He was diagnosed with croup. What is croup? Croup is laryngotracheal bronchitis. It is an infection of the upper respiratory tract that causes barking cough. Not whooping cough seen in diphtheria, barking cough like that. All right. Hello, Norman Deshmukh. So barking cough is seen. 3-year-old child, laryngotrachea will definitely go into like stridor, like has been in this case. They are not asking treatment. They are asking what is responsible for this. Parainfluenza are responsible. They are upper respiratory tract. Influenza also, and paramyxoviruses. Paramyxoviruses are like your measles, mumps, and Nipah. All of these are paramyxoviruses. They can all cause this. Pneumocystis jirovecii, which sounds, Jirovecii sounds like an Italian football player, but Pneumocystis jirovecii, like it is said in Italiano, they say the Pneumocystis jirovecii. This is usually seen as a part of AIDS. It's a pneumonia which is seen as a part of AIDS or HIV or any immunocompromised status. So this is not going to be responsible for it, but your other three, influenza, and paramyxoviruses, are all responsible for croup. All right, guys. Which of the following conditions will show a decrease in bone conduction in pure tone audiometry? Yeah, pneumocystis cerevisiae is fungal. Najib is correct. All right. Which of the following conditions will show a decrease in bone conduction in pure tone audiometry? So here, think about it. थोड़ा सा confusing हो सकता है. Where it will show a decrease. You are doing bone conduction in pure tone audiometry. There are multiple bone conduction tests that we do. We have the Wabax, we have the absolute bone conduction, we have the Bings, and we have the Jellies. Okay, we usually get very confused. Shahid Maksud is saying that in tympanic membrane perforation you will see a decrease in bone conduction. Now let me explain. What are you trying to test in bone conduction? Now in Schwabach's test, you are putting the tuning fork on the examiner and the patient, and you are seeing who is able to hear bone conduction sound longer. All right, so if you are able to hear bone conduction sound longer, then there is a problem in the, I will tell you. Schwabach's test, you don't close the tragus. Absolute bone conduction is same thing. You're testing it with the examiner and the patient. You're assuming examiner's bone conduction is normal, but you are closing or occluding the tragus. Bings, how to remember Bing? I used to remember it as finger on tragus, bing, finger, binger. All right, and Jellies is when you're using pressure, cesial speculization, cesial jelly. So that's how I used to remember. No logic in that, but otherwise नाम से कैसे पता चलता है यार क्या चीज है? That's one of the big problems with ENT. सब चीज नाम के ऊपर है. Abscess का नाम भी नाम, sign का नाम भी नाम, test का नाम भी नाम. And if you explain the condition, at least you can decipher it. अभी Jelly, Bing, Schwabach's are all names. At least absolute bone conduction, you know it's bone conduction. All right. So Jelly is because of cesial speculum, I remember, and Bing's because Bing sounds like finger. So like that. Now, guys, what are you think about it? Okay, I see you guys are confused. Fixation of footplate of stapes and tympanic membrane perforation is not the right answer over here. Look at the word here. They're saying decrease. Bone conduction is reducing. Bone conduction is basically cochlear function. It is cochlear function. Bone conduction is cochlear function. When your middle ear bone conduction mechanism is not working, you are bypassing it by placing the tuning fork on the mastoid, so that your skull is now vibrating the cochlea, because cochlea is also housed in the skull. It is housed within the temporal bone. So when your bone is vibrating here, those vibrations are vibrating the fluid in the scala tympani and scala vestibuli. Inside the cochlea, the fluid is going to shake. Because of the bone conduction. So if the outer part of the ear, the middle ear, is having some problem like fixation of stapes, perforation, or external auditory canal pathology or middle ear pathology, cochlear function is normal, so the bone conduction will be good. But if the cochlea itself is not functioning and you're going to do bone conduction test, it is going to decrease. Okay, so I'll repeat it. Shiv is saying that the voice is breaking. I hope you understood this part. It's a very important concept. Most people think bone conduction, you are testing the bone conduction of the middle ear. You are bypassing the middle ear bone conduction and you are directly triggering the cochlea to see if the problem is in the air pathway or it is in the bone pathway. If it is in the air pathway, middle ear, it will not transmit, but bone is directly going to cochlea. So you know cochlea is working. So that is how you come to know that middle ear mein problem hai. Right? So if it decreases, it is cochlear pathology. Okay, I'm spending some time on this because this is a basic I've seen many people misunderstand, which is also evident by some of the answers that you gave. Okay, so all these bone conduction tests are actually testing cochlear function, and I hope you understood that. Dr. Unknown is saying, I am Shambhu Raje this side. Now it is not Dr. Unknown. I know who you are. You are Shambhu Raje. Nice to meet you. All right. Treatment of atrophic rhinitis. Treatment of atrophic rhinitis is such a sad story. I don't know if you know the story of this. Young's operation is the treatment of atrophic rhinitis, but I don't know if you know कि इतना sad story है. ये Young जो doctor है, उसका नाम ही Young है. He was old at that point of time, 1960s में. What happened is these Britishers are a little insensitive and proud during that period of time. So क्या होता था in atrophic rhinitis, you have a lot of bad smell coming from the nose, but the patient has merciful anosmia. So the patient has merciful anosmia, cannot get the smell because everything is atrophied inside and all the way up to the olfactory area. So there was so much of smell and people used to complain, he stinks, I cannot breathe, I cannot smell him, every time he comes to a party we are not able to have a cup of tea because of the bad smell emerging from it. तो यंग ने क्या किया, इसने बोला नाक से स्मेल आ रहा है तो नाक बंद कर देते हैं. That is what they do in Young's operation. They make a flap, and if you, this is the nasal cavity, all right, this is the nasal cavity, they basically close it. He closed it and he left it closed for that person for 2 years. He's like, anyway तो सांस नहीं ले रहा है तो इसको बंद कर देते हैं, हम लोगों को तकलीफ हो रहा है. Imagine this guy did it for other people, not for the benefit of the patient. But by chance 2 to 3 years later, patient was saying, yeah, I'm not able to breathe, not able to breathe. He said, okay, let me open it up. And when he opened it up, the disease had reversed. And that is why we came to know why Young's operation works. Because the cause of atrophic rhinitis is a bacteria called, and when Klebsiella ozane is an aerobic bacteria. And when you close up the nose and you have made everything atrophic, this bacteria cannot survive. And when it does not survive just because of the sheer closure, ये मर गया, and regeneration started happening and patients started to improve. So now, like somebody has said, Najib is saying na rahe naak nahi rahe badbu. Correct, that's a that is what those guys mentality was. And now modified Young operation is done where a 3 millimeter opening is there. There's a 3 millimeter small opening. Jafar Iqbal Laskar is correct, and that is how Young, by not doing something merciful, became famous, because inadvertently he was able to treat this, even though उसके जो इरादे थे वो सिर्फ स्मेल रोकने के थे, ट्रीटमेंट के नहीं थे. ये बाद में पता चला क्लेब्सिला ओजेन की वजह से. तो ये स्टोरी याद रखोगे, इट्स प्रीटी फैसिनेटिंग. बट फंक्शनल एंडोस्कोपिक साइनस सर्जरी, nasal steroid immunotherapy don't really work. For this you have to get rid of this Klebsiella ozane. Okay. All right, what is true about BERA? Brainstem evoked response audiometry, also called as auditory brainstem evoked response. BERA, ABR, एक ही चीज़ है यार. Is it an invasive test? BERA, is it a subjective test done only for over 18, done for sensorineural hearing loss? Very straightforward. I think you should be able to answer this. What do you think is the answer to this question? All right. Sir, are there clinical case discussion videos on MedEd case presentations? Yeah, Shobi, we are going to be doing that actually. We are going to have to prepare you for next and for your exit exams. We are going to have these kind of clinical case discussions also. But here I'm trying to give you some clinical orientation. Most people are saying D, it's very straightforward. Shahid, Najib, Shubham, Chandni, you're all correct. It is done for sensorineural hearing loss. It is a brainstem evoked response, which is after the cochlea. So this is the cochlea. Now guys, in this BERA, these examiners are always trying to ask what is the pathway, and there are many questions that they will twist and tell you. Okay, so I'll tell you a simple way to remember this. So sometimes they will say spiral ganglion. Spiral ganglion is there inside the cochlea. From here, the cochlear nerve takes it to the cochlear nucleus. Okay, your first and second waves of the BERA, there are 7 waves. Those first and second waves are produced here. After that, what is the next part in the, when you go up in the brainstem? So first you have pons, then you have the midbrain. So what is the next thing after the cochlear nucleus? Do you know? What is the next path of the auditory brainstem response? Yeah, Rakiro, you're right. D is the right answer. Kef Khan also right. Shekhawat also right. But cochlear nucleus के बाद क्या होता है? हिंदी में बोलिए ना सयोन. हिंदी में मैं आपको बताता हूँ. cochlear nucleus. सब्जेक्ट इंग्लिश में भी नहीं है, ग्रीक और लैटिन में है. क्वेश्चन आपका इंग्लिश में आ रहा है, हिंदी में बोलिए ना. इकोलिमा. तो नजीब खान, इकोलिमा का मतलब क्या है? तो यू आर सेइंग ऑलिवरी. The olivary. Najib is saying olivary. See, this is where the confusion comes. You just need to know इसके बाद क्या आता है. What is the next one? And I know a way, kind of way that works to remember this. So there is something called as superior. Handwriting ऐसा हो गया पेशेंट को देख देख के. Superior olivatory nucleus. Okay, PONS. Superior olivary nucleus, or sometimes they put superior olivary center, or if they put superior olivary region or something, तो वो ये N चला जाता है. But you can get Pons word in superior olivary nucleus. So superior olivary nucleus के बाद आता है lateral lemniscus. Lateral lemniscus. हिंदी में बोल दूं lateral वहाँ lemnisca वहाँ. Okay, and then afterwards comes the inferior colliculus and medial geniculate body. Okay, these are all midbrain. Lateral lemniscus and superior olivary nucleus are in the pons. All right, these two are in the midbrain. Inferior collicus वहाँ and midbrain वहाँ, medial geniculate वहाँ, body वहाँ. समझ में आवत है? All right, so that is how it is. Mnemonics for Bera waves corresponding to the part of which it is on. यार वो mnemonics याद नहीं रहता ना. E. कोलिमा कोई बोलेगा, कोई लीमा बोलेगा, कोई EC के लीमा बोलेगा. मतलब you know, so sometimes once you get the superior olivary nucleus, remember it is superior, lateral gaya side में, it is second. Usually this is where they ask, they want to know the pathway. Most of your MCQs, if you can figure out 4, you will be able to figure out most of the you know, options. All right. Nasopharyngeal carcinoma is associated with which of the following viruses? Very straightforward here. इसमें time waste नहीं करेंगे. It is the Epstein-Barr virus. Epstein-Barr virus, herpes virus, class 4 I think बोलते हैं, herpes virus 4 उसका है. That is the Epstein-Barr virus is one of the most common causes of nasopharyngeal carcinoma. Cytomegalovirus, herpes zoster virus, parainfluenza virus, not associated with nasopharyngeal carcinoma. इसमें कोई logic नहीं है, इसमें just information है, so we will not waste time here. Pulsatile mass behind the tonsil is due to, okay, this is an interesting one. Behind the tonsil, so this is the uvula and this is the tonsil and there is a pulsatile mass. You are seeing the pulsations over here. Now, what do you think this is? No, Najib Khan, that is not kissing virus. Kissing virus is infectious mononucleosis, but correct, it is because of Epstein-Barr. You're right. Najib is very fast on the kissing, so that is correct. Epstein-Barr virus causes infectious mononucleosis and Epstein-Barr virus also causes nasopharyngeal carcinoma. Good way to associate that. Okay, so what do you think, guys? इसमें carotid तो चारों में ही है. अब क्या करोगे? You know it is because of carotid, but it is because of aneurysm? Is it because of internal carotid artery aneurysm? Is it because of external carotid artery aneurysm? Or is it because of carotid body tube that causes a pulsatile mass behind the tonsil? An anatomical question which is asked a bit indirectly, but what do you think it is over here? All right, will I tell you? It is the internal carotid artery. Internal carotid artery is the one that goes behind the tonsil. The external carotid artery is out here in the neck. Common carotid artery is not there in the neck area. So, and carotid body tumors are along the external carotid artery. So it is going to be internal carotid artery. And I know, so Shahid Maqsood is saying external carotid artery, external to bahar aa gaya. So this is in the internal carotid artery because it is behind the tonsil and tonsil is inside. So that's why this can be confusing. But remember, behind the tonsil is the internal carotid artery. Laryngeal crepitus is seen in all except, okay, I'm going to tell you how to do laryngeal crepitus test. If you hold your larynx, you hold your thyroid cartilage and you move it left and right, you will feel a grating sensation. Grating sensation मतलब जैसे कोई अदरक रेडिश को या मूली को जैसे ग्रेट करते हैं ना, या कोई भी गाजर को हम लोग छोटा छोटा करते हैं, ग्रेट करते हैं. You hear a grating sensation, okay? If you hold your trachea and you move it, that is the grating sensation, and that is a very specific indication. So you're asking laryngeal crepitus is seen in all except. So where will you see it? It is seen in all except. You will not see it in posterior cricoid carcinoma. Okay, because this is the thyroid cartilage and the cricoid cartilage rubbing on the vertebra. So suppose if it is a posterior cricoid carcinoma, the posterior cricoid carcinoma will be, the cricoid will be fixed. So cricoid will be fixed in posterior cricoid carcinoma. So this बोका साइन, बोका के बाद नहीं बोलेंगे, साइन बोलेंगे. बोका साइन मतलब वो तो वही जाता है, लेकिन बोका हो जाता है. बोका साइन इज व्हेन यू आर ट्राइंग टू मूव द थायराइड कार्टिलेज एंड यू डोंट सी अ ग्रेटिंग साउंड. देन बोका ने बोला कि अभी ये कैंसर हो सकता है. द क्रिकॉइड इज फिक्स्ड. बट इन नॉर्मल पीपल, इन laryngitis, in bronchial carcinoma normally present to all individuals, boca sign will be positive, and you will see, you will hear the you will feel the grating sensation over here. All right, so very straightforward. Dolman, Dolman operation is done for what? This I'll wait for you to answer. I know thoda sa lag 1 minute ka, so wait karega. Dolman's operation is done for done for pharyngeal pouch, diverticulum below, cricopharyngeal area, laryngeal web, epiphrenic diverticulum. किस चीज के लिए करते हैं Dolman's operation? Does anybody know? Does anybody know the answer to this question? Dolman का ऑपरेशन किसके लिए करता है? फरेंजियल पाउचवा के लिए करता है कि डायवर्टिकुला के लिए, कि इधर जो वेब बनाया है उसके लिए करता है. Zenker's, Najib Khan is saying Zenker's. Zenker's diverticulum is right. Rakhi, Shayad, and all of you are correct. It is the pharyngeal pouch, also called as Zenker's diverticulum. इसमें जो cricopharyngeus muscle है वो काटते हैं and you push this pharyngeal pouch or the Zenker's diverticulum back. The Zenker's diverticulum is a gap between the thyropharyngeus and the cricopharyngeus. There is a weak spot called as the Killian's dehiscence. And this Killian's dehiscence is the part where there is a weakness because एक circulatory fiber है और एक vertical fiber है, उसके बीच में there is the space जिससे ये herniate हो जाता है, this Zenker's diverticulum. Okay, so here you will see Boyce sign. Boyce sign is that if you press the Zenker diverticulum, you'll hear some fluid gurgling. Gurgling sign, Boyce sign, is seen in Zenker's diverticulum and one other condition, which is laryngocele, the trumpeting, and that both of them, any herniating pouch which has fluid inside will show the Boyce sign. Okay, so I hope you are able to understand that. Most appropriate investigation for juvenile nasopharyngeal angiofibroma is, the word is most appropriate. Okay, they're not asking feeding vessel, they're not asking any other thing. They're asking which is the most appropriate. Most appropriate will be contrast enhanced CT scan, CECT, contrast enhanced CT scan, because you want to look at the bony erosion. And yeah, Raki is right, Killian's dehiscence lacks any muscle, that's why it's a gap between the cricopharyngeus and thyropharyngeus. And alright, so here why you want to do CECT in juvenile nasopharyngeal angiofibroma and contrast enhanced, because it's a vascular, benign, non-capsulated tumor. It is a benign, non-capsulated tumor which invades the sinus, maxillary sinus, the sphenopalatine area, and all of that. And to see bone, you have to see CECT. Unfortunately, MRI is not a very good thing for the skull because of what the bone does not give very good images. All right, for the sinuses and the nose. But angiography is to know the digital subtraction angiography can be done to know which is the feeding vessel. Does anybody know what is the feeding vessel to the juvenile nasopharyngeal angiofibroma? What is the vessel, blood vessel to the juvenile nasopharyngeal angiofibroma? ये question भी काफी पूछा जाता है. I'll wait for your answer, though there is a lag, so please bear with me. What is the blood supply or the feeding blood vessels to juvenile nasopharyngeal angiofibroma? Let me wait for some answers from you, and then we'll move fast for the remaining questions. We will spend too much time because I think most of the concepts I've already shared, and I know you must be tired, so the next 20 minutes हम solve कर देंगे. Najib Khan is saying sphenopalatine. Yeah, so basically it's a maxillary artery, internal maxillary artery branches, and the major part is by the maxillary artery, which will be the sphenopalatine artery and the descending palatine artery. The sphenopalatine and descending palatine are the main branches. Raki Roy is also correct. Internal maxillary artery is the branch, but there is also ascending pharyngeal and ascending palatine. This is from the carotid artery and this is from the facial artery. And they also contribute, but they contribute slightly lesser. Okay, so let's move to the next one. A boy with history of ear discharge presented with pain in the ear and hearing loss. On examination, redness was behind the ear. Reservoir sign was positive. What is the most likely diagnosis? Reservoir sign is seen because of pus in the mastoid. Because the mastoid, when you're lying down, when you lie down, all the pus gets doing. So what is the accurate answer? Raki is asking. Did I not answer it? Yeah, accurate answer. CECT is the accurate answer. All right. So a boy with history of ear discharge. So this is reservoir sign seen in mastoiditis. Okay, very straightforward. Time waste nahi karenge. Let's move on. A doctor posted in ICU. I'm sure we have all done this. Came to the OPD in April 2020. में क्या हुआ था? With loss of smell and taste for 3-4 days. क्या है ये? है COVID. So what is the next step in COVID? Confirming it and isolating the person. Nasopharyngeal swab. I think life has taught us the answer to this question. We don't really need any more learning. Patient presented after being slapped 3 days ago. Decreased hearing. No pain. Pain is usually because of the stretch of the tympanic membrane. So no pain, matlab, you know, there is this thing. Rocky saying artery names sphenopalatine internal. Sphenopalatine artery is the branch of internal maxillary artery. The two branches of internal maxillary artery, sphenopalatine artery and descending palatine artery. They are the two branches, but they are coming from the internal maxillary artery. So in your option, agar internal maxillary artery aata hai, then that would be the right answer because these are the two sub branches of it. All right. I hope I clarify that doubt for Raki. Okay. So what is the next line of treatment? First of all, ये जो image है, this is not occurred from a slap. Okay, this is you know, a non-healed perforation. You know, nowadays we don't say safe and unsafe ear anymore. We say active mucosal, which is used to be the safe ear, and active or inactive. ठीक है? Active मतलब pus है, inactive मतलब कोई pus नहीं है, and active inactive squamosal. Active inactive squamosal is basically for unsafe ear. This image actually is of an inactive mucosal ear, but image कुछ मिला नहीं होगा perforation का. When you see a slap, you will only see let's say the same eardrum. You will basically see 1 or 2 tears like this and some blood. That is how you will see it will be dried up blood. So that is how the image of slap related trauma will be. And your treatment of approach for acute trauma is where there is a rupture is going to be wait and watch, because the eardrum will heal. The eardrum will heal if you keep it dry. It will take 3 to 5 weeks, but it will heal. And when it will heal without the fibrous layer. Fibrous layer is the middle layer. The tympanic membrane develops from all 3 germ layers: ectoderm, mesoderm, endoderm. Ectoderm forms the squamous layer, mesoderm forms the fibrous layer, endoderm forms the respiratory epithelium that is there inside. But when it is rehealing, the squamous layer and the ciliary epithelium, the respiratory epithelium recovers, but it does not. So it will appear like a very thin healed perforation. Some of the other questions that may be associated. We will wait and watch, we will not do anything else over here. We'll find the person who beat her or beat the person. I don't know why I'm saying her. It could be any patient. It could be 2 people, men also fighting. So whoever has done the assault, they will have a legal implication. We have to find that person. This will heal. If it doesn't heal, then we will do a tympanoplasty, right? Boy fell down while playing, presented with deviated nose. Oh, I don't think you can see this image. So aisa karte hain. I think now you can see. All right, this is the deviated nose, and septum was found to be normal, but this X-ray, even though they say septum is normal, I think you can see a depressed fracture of the root of the bone. So mark kar deta hu. There's a depressed fracture here. Okay, so now I think you will be able to see there's a little depressed fracture over there. So what will we do? Whenever there is a fracture of the nasal bone, we are going to wait for the edema to settle. Okay, there will be a lot of edema. I think we had another question in the beginning, jab bola tha swelling around the nose and nasal blockage, and bleeding. That is very classical and typical of these nasal bone fractures. अभी आपने तुरंत उसको करेक्ट कर दिया तो फिर वो जो एडिमा से आपको पता नहीं चलेगा कि आपने ढंग से करेक्ट किया है कि नहीं. You will not know whether you've corrected properly. So you will do close reduction after edema subsides. Whether you do surgery or whether you put a cast over here, you will wait for the edema to subside and then you will apply the pressure and you will try to get it healed. All right. A professional trumpet blower, somebody who had already predicted trumpet blowing, I don't know whether it was Raki or it was somebody else, said that when there's left-sided neck swelling because of trumpet blowing, here you can see in the x-ray, this is the angle of the mandible, this over here is the airway, this is the person जिससे हमने ये इमेज चुराई है, इसको हटा देते हैं, this is the vertebra. Okay, so all of this here you can see black means air is black on x-ray. So this is basically laryngocele. Okay, so a laryngocele, when there is increased pressure trumpeting, because the air is going into the airway, it comes out. In pharyngeal pouch, it has to be pressure, not air. There could be weightlifting or something else. Could be even coughing. Coughing can cause this because it's intra-abdominal pressure. But here laryngocele, there is air going inside the lungs. That's what they're trying to say. Trumpet बोल के ये बोल रहे हैं कि हवा आपके airway में जा रही है. So that's why laryngocele is the answer here. Patient present with carcinoma pyriform fossa. So pyriform fossa. If I draw the adenoids like this, and this is the fold. Now this is the vocal cords. All right. So this triangular spaces over here. This is the pyriform fossa. Okay, pyriform fossa is a part of the hypopharynx. Hypopharynx, because it is a pouch. It is in three-dimensional. It is like this. It is thoda niche hai. Yahan se it is looking. It is the same level of the vocal cords. It is down. It is a food pouch. When we swallow, it first goes to the pyriform fossa, so that it does not go into our windpipe. And then when we swallow, the epiglottis, the esophagus opens, and the pyriform fossa everts, and it puts the food inside. So pyriform fossa, you are saying here, what is the most important thing is the folds are not mobile. Okay, fixed vocal cords. I said vocal cords and vocal folds are the same, and fixed, once the vocal cords are fixed, it is T3. Very, very straightforward. If you know the TNM classification, T1 and T2 are usually one side, two side, but mobile cords. In most of the, even if you take the supraglottic, or even if it's called smuggler's fossa, Najib Khan is good with all of these trivia. T1, whenever T1, T2 are usually single side, two sides, or esophagus, but mobile vocal cords. The moment vocal cords get fixed, it is T3. T4A is spread to the larynx structure like your thyroid cartilage and all of that, and T4B is far away structures like the lungs or other areas. Okay, and lymph node to the henny, metastasis henny, so it is very straightforward over here, pyriform. All right. Patient presents with hoarseness of voice. On examination, ulceroproliferative mass seen on the right vocal cord. So vocal cord either is yes and okay, so एक इधर vocal cord, एक इधर vocal cord, ये adenoids, got fold, and ये pyriform on either side. All right. Now, Raki, yes, these are PYQs. These have been asked in the past, and usually in FMG we have seen a very good recall of PYQs in FMG. They do repeat a lot of the questions or the same concepts in a different way. ज़्यादा एफर्ट नहीं दे रहे ये लोग दिमाग लगा के क्वेश्चन बनाने का. तो ये ट्रेंड देखा है कि बहुत सारे क्वेश्चंस, लॉट ऑफ क्वेश्चंस आर बीइंग आस्क्ड बट दे बीइंग रिपीटेड. ऑलराइट, सो पेशेंट प्रेजेंट विद होर्सनेस, देयर इज एन आल्सो प्रोलिफरेटिव मास. ये राइट है, ये लेफ्ट है. सो ऑन द राइट वोकल कॉर्ड, एंड द कॉर्ड इज मोबाइल, नो लिम्फ नोड, नो मेटास्टेसिस. Which of the following is the best treatment? Remember the word best. Best treatment over here will be radiation therapy or radiotherapy, because if vocal cords are mobile, why do you want to cut and remove and excise the vocal cord and cause vocal cord mobility issue? They respond very well to radiotherapy. Radiotherapy is very good for nasopharyngeal carcinoma. It is very good for laryngeal cancer. So the larynx. So all of these things you can do this. All right. So radiotherapy is answer. Most common site of obstruction by nasal polyp and maxillary sinus, very very simple. इसमें ज़्यादा time waste नहीं करेंगे. So if this is the maxillary sinus, you know it is coming in the middle meatus. So middle meatus में आ रहा है. So middle meatus is where this polyp is going to come. So let's not waste time on this. Very very straightforward. That's where the maxillary sinus drains in the hiatus semilunare, which is in the middle meatus. So polyp भी वही block करेगा. Following is an endoscopic image of nasopharynx. Identify the encircled site. Now encircled site, you should not get confused. These arrows, this is pointing to the eustachian tube opening. This bulge is the torus tuberous, and this fossa is like this depression. This is the fossa of Rosenmuller, German. Okay, so Rosenmuller is the endoscopic image. Encircled site over here is fossa of Rosenmuller. This is the site of origin for nasopharyngeal carcinoma. Adenoids arise from here. Okay, above the adenoids you will have the ractase pouch. This ractase pouch is what forms the anterior pituitary gland. Rakhi Roy, eustachian tube is this white arrow. This is the eustachian tube. This is a tube going like this. Okay, so this is the eustachian tube. This is the torus tuberous, and this is the fossa of Rosenmuller. Okay, and ractase pouch is above it. You also will have the adenoids which come from here. Gold standard investigation before FES. No need to waste time on this. It is CT scan. CT scan is our GPS. It is our map. When I'm a nose and sinus surgeon, without a CT scan, it is not legal to even operate on someone, because this tells you the bony involvement and the extent of the disease. If I want to know what are the bony abnormalities, I don't want to know it when I'm going in with the endoscope. I have to know whether there is any abnormal cells, like there is the onode or there is the hallers. I have a very funny way to remember this. onode has sphenoid, स्फिनॉइड का नॉड है, और हैलर में 2 L लगे हुए हैं, और फेस में L तभी लगते हैं जब लैमिना के पास होता है, लैमिना पेपरेसिया का डैमेज होता है. तो हैलर सेल इज क्लोज टू द लैमिना एंड ओनोडी सेल इज इन द स्फिनॉइड एरिया, एंड दैट इज हाउ आई यूज्ड टू रिमेंबर इट. नहीं तो ओनोडी और हैलर तो सिर्फ नाम है यार, नाम से कैसे पता चलेगा कि क्या चीज़ है. दैट्स व्हाई आई डोंट लाइक द नॉमेनक्लेचर्स इन ENT, बट आई होप दिस हेल्प्स यू. Syphilis affects which part of the nose? Very straightforward question. It affects the bony septum. It causes bony septal perforation, very common in syphilis. Let's not waste time over here. All of the following are true about the patient with this lip mass over here. Just remove the person. Okay, lip mass over here. All of the following are true except, मतलब which of the following is false. यही decode करना पड़ता है हमको. Okay, now mucocele, it's a mucocele, right? Ranula is also mucocele. Now it is usually a retention cyst because of the blockade of the mucocele. It is true, whether it is usually a retention cyst. When it is small, a mucocele is a retention cyst, but when it is big, it becomes extravasation. And so extravasation is actually quite common. It is not that common, so the answer would be C. Painless mass, translucent is fine. Recurrence is common after excision is also fine. But extravasation is not a rare thing. Extravasation, especially for such a large one, extravasation matlab it is moved out of its capsule and it is covered around the area around it. Okay, like the ranula. So retention cyst is it is retaining the wall, and extravasation which is outside. And extravasation is actually quite common because of trauma as one of the sources or the reason. Pharyngeal pouch is located between, इधर देखो ये एक आंसर है जिसमें थोड़ा सा स्पेशल हमको दिया गया है. It is between the thyropharyngeus and cricopharyngeus and between the inferior constrictor and esophagus, and this is the Zenker's diverticulum. We've already covered this, so we won't waste time here. Now, patient underwent removal of submandibular gland and lingual nerve was damaged during surgery. Which of the following is not correct? Now here examiner is trying to confuse you, so I'm going to spend some time over here to help you understand what is being asked, and I want to know what you think is the answer. Okay, listen very carefully. Patient underwent removal of submandibular gland. Submandibular gland को हटा दिया and lingual nerve was damaged. Which of the following is not correct? Which of the following is false? Which of the following झूठ है? Now, yeah, Rakiro, that means extravasation is not rare. It is common. That is why it was confusing. That examiner wanted to confuse us. All right. The examiner wants to confuse us in this question also. And I want to see whether you're getting confused or not. So I want to know what is your answer to this question. Will the rate of the sublingual or submandibular secretions be reduced? Or like Shahid Maqsood is saying, is anterior two-third tongue taste is lost? Or is the sensation of floor of mouth lost? Or is tongue deviated to the side? Which of the following is false when lingual nerve damage happens? This is a trick question, so I want you to think about this carefully and tell me the answer. I want to hear one or two more answers. What do you think it is? So Shahid Maqsood has said B. और क्या हो सकता है? Tongue deviated to side is said by Raki. Okay, so which is correct? Is this correct or this correct? Now here's what happens, right? Whenever we think of anterior two-third of the tongue, we are thinking about chorda tympani nerve. Okay, very common mistake. Chorda tympani nerve, the moment we think about anterior two-thirds of the tongue. But you have to know that chorda tympani is the efferent and lingual nerve is the afferent. It's called a special visceral afferent. So whatever taste the chorda tympani is bringing to the anterior two-thirds, you're able to feel that taste only when the lingual nerve takes it back to the central nervous system through the special visceral afferent. So if the lingual nerve is damaged, whatever taste sensation that the chorda tympani brings, it is not going to reach your brain, so you are going to lose taste even in lingual nerve damage. That's why I said this is a trick question. But the answer is actually very obvious. The lingual nerve has a special visceral afferent and it has a general visceral efferent. General visceral efferent gives the submandibular and salivary gland, sublingual gland ka secretions. Okay, it gives the secretion. It is the efferent. Efferent means away from the central nervous system. Afferent is to the central nervous system. So it is producing the saliva and releasing the saliva, and it produces floor of the mouth sensation also. But tongue movement is only by hypoglossal nerve, no other nerve. When there is hypoglossal nerve palsy, only the tongue will deviate. There is no muscular supply of the lingual nerve, so the tongue will not be deviated to the side in lingual nerve damage. And they have given you this anterior two-third by making you quickly think that अरे anterior two-third तो chorda tympani है, lingual nerve का क्या लेना? But lingual nerve is the afferent of it, right? दो नर्व लगते हैं एक सेंस ऑर्गन करने के लिए, एक जो सेंसेशन लाता है और ये ब्रेन में परसीव कराता है, राइट? So that is why some of these trick questions can come. This is a tricky one. At the first thought, if you are a shortage of time, आप इसको तुरंत click कर दोगे, but you need to think about it because tongue deviated to the side has to be hypoglossal. That is the muscular supply to the tongue, not the lingual nerve. All right. So Raki, you were correct. Because you just saw what was, because if you think that lingual nerve का क्या लेना देना है tongue movement से, it will be more obvious. But if you just get attracted to this anterior two-third, then you will get confused. तभी ये ऑप्शन ऊपर दिया हुआ है और tongue deviated बाद में आ गया क्योंकि आप इसी को देख के टिक कर दोगे. Alright, few more questions left, guys. Let's do this quickly, rapid fire, next 5-10 minutes. 15-year-old male patient presented with nasal mass reaching up to cheek, causing unilateral obstruction and intermittent epistaxis. 15-year-old male बोलते ही juvenile nasopharyngeal angiofibroma, epistaxis, no need to waste time. Structures not seen in indirect laryngoscopy. Indirect laryngoscopy is you're using the mirror and you're seeing the vocal cords as a reflection, right? So what are the structures that are not seen? You will see the anterior commissure, which is the part where the vocal cords meet front. You will see the posterior commissure. You will see the epiglottis. Epiglottis is here in the front, which protects the layer. So the structure which is not seen is going to be false vocal cord. False vocal cord समझने के लिए you have to look at the cross section. So if I'm seeing this is the thyroid cartilage, and if this is the true vocal cords, okay, false vocal cords are at another level and there is a space between the two. Okay, so that is where that space can only be seen by cameras and the angles. You cannot see it with the mirror, because there is a space between the true and false vocal cords, and sometimes there is hidden cancers and infections that can spread there. Okay, all are parts of the hypopharynx except. So let me draw the vocal cords. Okay, this is the arytenoid, area epiglottic fold. Okay, and then this is your pyriform fossa. Okay, so your hypopharynx has the pyriform fossa, posterior pharyngeal wall, and the cricoid area, post cricoid area, because all of that is there. Your vallicula is seen here near the base of the tongue. That is not a part of the hypopharynx. That's supra, not even suprapharynx. That's actually posterior part of the oral cavity and oropharynx. Vallicula is a part of the oropharynx actually. So vallicula is the answer. Narrowest part of the airway in the infant is very straightforward. It is the subglottis in infants. Okay, subglottis is the narrowest part. That's why subglottic stenosis is a very big problem. And yeah, Najib, you're right. 3P is also a good way to remember. Sare trivia Najib ke paas hai. Contact him for any trivias that you want. Narrowest part of the infant is the subglottic. Subglottic stenosis, most common in kids to cause what kind of stridor? Subglottic stenosis causes expiratory stridor, supraglottic causes inspiratory, and glottis causes biphasic. How to remember? Just the flow of direction of air is there, because of Bernoulli's phenomenon, the structures close. So when the air is going inside, the supraglottic structures close. When it is expiration, supraglottic structures will be moved away, but subglottic structures will be pulled up. That's how the stridor happens. Simple physics, no need to by heart कि supraglottic inspiratory है कैसे याद करेंगे. Think about the physics of it. All right. Now, which of the following muscles are life-saving of the muscle of the larynx that pulls back the vocal cord in order to breathing take place? There is only one abductor. Abductor matlab who takes away. That's why abduction is kidnapping. Abduction is moving the cords away. There is only one abductor for us, which is posterior cricoarytenoid, and we need our airway to be open for us to breathe. So posterior cricoarytenoid is called as the life saving muscle. But idhar ek important point hai. Now, when there is bilateral recurrent laryngeal nerve palsy, why do we have stridor? Because if you see the vocal cords, the cadaveric position of the vocal cords is actually quite broad. Okay, there is a lot of space because that is the cadaveric position. But what happens is, when the abductor is paralyzed, cricothyroid is an adductor, and it is the only intrinsic laryngeal muscle that is supplied by the superior laryngeal nerve or the external laryngeal nerve. So this is spared in recurrent laryngeal nerve palsy, and being an adductor, it pulls the vocal cords in the median or the paramedian position, causing stridor. This is called Wagner and Grossman's hypothesis. Okay, and this is why it is very important to know that why we go into stridor when there's bilateral recurrent laryngeal nerve palsy is because of the adduction power of cricothyroid, because its supply is not recurrent laryngeal nerve, it is superior laryngeal nerve. So this is the part that examiners usually try to see. Agar aapko ye concept pata hai, that's where they twist the questions around. So it's good to know this. What is a causative agent for malignant otitis externa? Yeah, Raki, you're right. Posterior cricoarytenoid is the only abductor. Malignant otitis externa is caused by pseudomonas. इसका नाम ही pseudo है, इसका नाम ही true नहीं है. It is not a true monas. It's a pseudomonas. Imagine, जिसकी identity ही false है, वो जो बीमारी करेगा वो तो malignant otitis externa जैसे devastating चीज ही कर सकता है, क्योंकि psychological trauma ही इतना होगा इसको, यार मेरा identity ही false है, that is his true identity. pseudomonas don't worry मोने, pseudomonas का true identity यही है कि वो false है. And staph, strepto and influenza don't cause malignant otitis externa. I hope that helps you remember this. A patient who recently got denture fixed, found with oral thrush, candidiasis. It bleeds on scraping. Okay, what is a causative agent for this? The patient had denture fixed, found oral thrush, treats on scraping, candidiasis. Anybody who's having some yeah, Najib, fake person got a lot of mental trauma. Yeah. So candidiasis is the very straightforward answer here. Anybody taking steroid inhalers or dentures or poor oral hygiene, or also somebody, nowadays there's a new question asked, if somebody is using a lot of alcohol mouthwash, दारू लेके माउथवॉश कर दिया या अल्कोहल रिच माउथवॉश कर लिया, it kills a lot of the normal commensals and promotes candidiasis. So it is B, not A. Diphtheria, if it is a tonsil, if it was a child, then it would be A, but this is oral thrush. Thrush is another word for candidiasis after a denture is fixed. All right, lady Najib Khan, candidiasis does bleed on scraping because the candidial layer when it is formed, and plus because of excessive steroid usage, there is a lot of mucosal trauma, inflammation, redness. So when you are doing the scraping, the bleeding is occurring not because the membrane is attached to the lower layers. It is because the edema and the inflammation and the steroid usage or whatever inflammatory process going there causes easy bleeding, and that is why that is there. But oral thrush is actually a synonym for candidiasis. If they were giving you a hint of diphtheria, then for diphtheria they have to tell either it's a child, they have to show tonsillar membrane. The diphtheria is not going to cause membrane on the tongue and all of these other places. So with this 2-line question, it does not indicate anything for us to think it is diphtheria just because of the scraping wala point. So hope you understand that. Bhavna Sharma is saying it is CSF rhinorrhea. Now I don't understand, scooty ko kyun badnaam kar rahe ho idhar. Lady comes to OPD, fall from scooty, vitals are stable, she is having continuous clear watery discharge from nose. What does this mean? This means it's a longitudinal fracture of the temporal bone. Okay? Temporal bone ka longitudinal fracture causes CSF rhinorrhea or can cause CSF otorrhea because from the middle ear the CSF can leak into the nose, or it can be just damage to the base of the skull. Middle cranial fossa fracture will not cause this, but normally vehicular fall is longitudinal fracture. Transverse is head-on injury where you will have facial nerve palsy and hearing issues. All right, but otorrhea, CSF otorrhea, CSF rhinorrhea more in longitudinal fractures. Office headache is due to inflammation of which sinus? Though it is related to your work and your boss, but the correct answer over here is office headache is related to frontal sinusitis, because throughout the day the inflammation keeps increasing and it blocks the frontal sinus recess area over here, so you get an evening headache. Whereas in maxillary sinus you have a morning headache where you're lying down and your sinuses are full, but as you're walking the drainage is occurring better. Straightforward basic question, time nahi waste karenge. Adam's apple in the male is due to thyroid cartilage. कोई इसमें time नहीं waste करना है. Cricoid पीछे है, thyroid ऊपर है, epiglottis का दिखता ही नहीं है. Thyroid cartilage, ठीक है? This is a thyroid cartilage. We are moving over here. Okay. Most prominent larger air cell of the ethmoidal cell is the agar nasi. It is the first pneumatized ethmoidal cell. It is not seen in all people. It is seen in roughly 40% of the population. When you enter and you see the middle turbinate like this, this is the septum, this is the inferior turbinate, this is the middle turbinate, you will see the bulla and you will see the uncinate process. Okay, I don't know if you are aware of the anatomy. This agar nasi cell will be seen first only, and is lateral to the agar nasi cell is the nasolacrimal duct, which we do in bacro cystorhinostomy. Haller cell में L लगे हुए होते हैं, और L तभी लगते हैं जब lamina peparissia involve होता है. So Haller cell is just below the lamina peparissia. Onodi cell is the sphenoid cell, and bulla ethmoidalis is this ethmoidal bulla. Very straightforward anatomical question. Treatment of choice in nasopharyngeal carcinoma. Nasopharyngeal carcinoma treatment of choice is radiotherapy. Juvenile nasopharyngeal angiofibroma, you do surgery because it's a benign tumor, but nasopharyngeal carcinoma has got extensive spread, sinus of Morgagni, eustachian tube close to the carotids. You do radiation therapy as the first treatment of choice. All right, why not bulla ethmoidalis is being asked. Bulla ethmoidalis is not the most prominent and larger air cell of the ethmoid. It is most prominent if the agar nasi is not there. but agar nasi is much bigger and it's the largest cell. So the cells move from big to small. So when you're going for ethmoidal cells, they're always big to small. So whichever comes more to be the biggest. It's not like it will the ethmoidal cell एक छोटा cell बनाएगा फिर बुल्ला बड़ा बनाएगा फिर ऐसे बनाएगा. They're big to small cells, and that is why it is there. Radiotherapy question is repeat. Okay. Now a 6-year-old boy comes to hospital with complaints of sore throat and difficulty in swallowing. Yeah, Raki, they love radiotherapies, but it's also because you know, that is where people think nose mein to surgery hi treatment hota hai. 6-year-old boy, sore throat, difficulty in swallowing, this odynophagia. Whenever they put this line that the tonsil was pushed the uvula. Okay, this is uvula. If the uvula is pushed medially, tonsil is pushed medially, all of this medial wala question aata hai, it is more or less peritonsillar abscess. Okay. Oh, sorry, here my bad. Here they are saying there is swelling on the left side of the neck, parapharyngeal abscess. Okay, parapharyngeal abscess, you will not see neck swelling, you will only see uvula being deviated. So just see how by a simple thing your diagnosis will change. All right. So in quinsy, you are not going to see any swelling on the left side of the upper part of the neck. Only when it is parapharyngeal on this side, you are going to see it, and that is going to change our answer to parapharyngeal abscess. All right. So I hope you understand that. If this swelling was not there, I would have also leaned towards peritonsillar abscess, but I know in quinsy you don't have outer swelling. Angiofibroma bleeds profusely because I've already answered this. The vessels lack contractile component, they don't have muscular layer, they don't have muscular layer, and they don't have the elastic contractility. That is why angiofibroma bleeds. Last few questions left, guys. Otomycosis is commonly caused. Now इधर थोड़ा सा हम लोग racist हो जाते हैं, because we always think whites are the most common answers and common things, and we think that okay, Candida albicans would be the most common answer, but you will be wrong. Just like in life, most common Aspergillus niger is the answer that causes otomycosis. Candidiasis is more that is there in the oral cavity, oral thrush, but in the ear, candidal infections are not so much. Aspergillus niger is more because of the stuff that we put inside to clean and all the fungus that comes from outside inside. Pix-Hallpike maneuver is done for vestibular function. It is a balance test done to diagnose BPPV. So those otoliths in the 3 semicircular canals, the otoliths have to be sent back. So to test whether the otolith is causing the problem, you do the Hallpix maneuver, which will trigger the semicircular canal and cause nystagmus. Remember, peripheral nystagmus will always have lateral or torsional nystagmus. Vertical nystagmus will always be central. So वो point कर रहा है brain या point कर रहा है towards ear. Okay, so that is what it is. Life-saving muscle of vocal cord. Again, this has been answered. Posterior cricoarytenoid, the only abductor. Okay, you already spent time on this. Miculic cell and Russell bodies. Miculic cells, foamy macrophages, and Russell bodies, eosinophilic inclusion bodies, are seen in rhinoscleroma or rhinosporidiosis. It is seen in rhinosporidiosis. All right, which is also got strawberry ear, strawberry nose, ponds, parasitic infection. Rhinoscleroma is caused by Klebsiella rhinocleromatae or Klebsiella pneumonia. Also, there have been some causes. All right, or is it rhinoscleroma? Am I getting confused here? I'll just quickly check. I don't want to give you the wrong answer, but as far as I thought, कभी-कभी ये rhino देख के मैं भी confused हो जाता हूँ. So let us see. Miculic cell is what? Yeah. Yeah, you guys are right. It is rhinoscleroma. मैं थोड़ा सा नींद में कंफ्यूज हो गया राइनो देख के. It is rhinoscleroma. You're right. You're right. Good. I was just testing you. Acting अच्छा करता हूँ ना. Okay, सर चिपक गए. नहीं सर चिपक नहीं गए यार. वो टाइम हो गया. Okay. Young's operation is done for atrophic rhinitis. We've already done this, and the history of Young's we already know that. So इस पर time waste नहीं करेंगे. Toby ear test is done for Toby ear test. इसमें क्या करते हैं? You press the jugular vein. Okay. If the CSF pressure increases, that is normal. But if you press the jugular vein and if the CSF does not increase, there is lateral sinus thrombosis. Okay, so that's why it is Toby ear test is for lateral sinus thrombosis and not the other things. Most common manifestation of nasopharyngeal carcinoma. Trick question here, guys. Trick question. Most common manifestation. Sometimes they will ask most common finding or sign. Okay, now here normally you will lean towards cervical lymphadenopathy, but because they've given nasal obstruction occurs in 100% of the cases of nasopharyngeal carcinoma. Cervical lymphadenopathy is next. Epistaxis, headache, and all of those is later. All right. Now, a 15-year-old male presented with a history of fever for 2 days, unable to swallow the food with a muffled voice. Tonsil shifted to the midline. Now, see, here they are saying it's a child. Tonsil is shifted to midline. They are not talking about any outer swelling. They are saying muffled voice because you see hot potato voice. I have never heard a hot potato talk, but I think what they mean by hot potato is a little gruff, potato-y voice, and it is quinsy or peritonsillar abscess. Adam's apple in boys is in thyroid cartilage. I'm telling you, PYQs इतनी बार repeat होते हैं कि PYQs की repeat session में भी questions repeat होते हैं. So be very thorough with the PYQs. A 35-year-old female presents with tinnitus, vertigo, fullness of ear. This is the triad: tinnitus, vertigo, fullness of ear because of increased endolymphatic pressure, Meniere's disease. Meniere's disease, when there is severe to profound hearing loss, sensory neural hearing loss, you will see a false negative rhinitis. That's why remember, if you want to get your audiology questions right, first note the side of hearing loss, then Weber's, then rhinitis, and the interpretation of all three will tell you, not individually. Because once you know which side the complaint is, then you will know whether Weber's is deviating, is lateralizing to the same side or the opposite side. Conductive sensory neural उसी समय पता चल जाएगा. And then when you do rhinitis, you will know whether it's conductive pathology or false negative rhinitis. So always remember this sequence. It will help you a lot in the exams. First notice the side of hearing loss, then do the Weber's, and then do the rhinitis. If you mess up this order, you will get confused and most likely will then get the wrong answer. All right. Picket fence fever. Picket fence fever is seen in lateral sinus thrombophlebitis. Very old question. आजकल ये सारे formats होते नहीं है because of use of antibiotics and other things. But you keep having picket fencing or rising and dropping of fever. Which of the following muscles originate from the first pharyngeal arch? Pharyngeal arch or branchial arch. The first arch is mandibular nerve. Second branch is facial nerve. Third branch is glossopharyngeal nerve. Then the fourth is superior laryngeal nerve. And sixth is recurrent laryngeal nerve. There is no fifth. Fifth illai. क्योंकि fifth बना ही नहीं. किसी ने 1 2 3 4 6 लिख दिया and गलती नहीं मान रहे कि 5 नहीं लिखा था. Anyway, हमको याद करना पड़ता है. So if you know which nerve is supplying which muscle, you will know which arch it is. So here only I think the anterior belly of digastric is supplied by mandibular nerve. I think stapedius muscle and posterior, this is facial nerve. Facial nerve, stylopharyngeus is glossopharyngeal nerve. So that is how I remember the arches, because you see the nerve and you see what it is supplying and you will be able to get the answer. Dip at 4K. Dip at 4K is noise induced hearing loss. Dip at 2K, which is called Carahart's notch, this is seen in otosclerosis. Okay, this is 4K, noise induced hearing loss, right? Continuous watery discharge from nose after trauma is most likely a feature of CSF rhinorrhea. Basically, they have given the definition of watery discharge from the nose, CSF rhinorrhea, right? Now, which of the following structures is used as a landmark for facial nerve? Tragus pointer. You see this tragus? So if I draw the ear, there is this tragus 1 centimeter deep and slightly anterior. Just 1 centimeter deep and slightly anterior is where you will find 1 centimeter deep and slightly anterior to this tragus is where you will find the tragus pointer, not the other things. Okay, posterior border of mylohyoid idhar hai, tip of helix idhar hai, it's not there. Najib, you're right about the target sign. Mainstay treatment of glue ear. Remember the word mainstay. When it is mainstay of the treatment of glue ear, it is going to be myringotomy and giving grommet or aeration. Definitive, confirmative management, full comprehensive management, you would do tonsillectomy and adenoidectomy also. Okay, if there was an option which had both of these, that would have been the ideal, but the mainstay is to, you know, drain it. Myringotomy is done when you're just making an incision, right? If I draw this malleus, the lateral process, cone of light. So ye anterior, ye posterior. We will make a cruciate incision posteriorly because when person is lying down, it is at the dependent position and the pus will come out. All right. But if you're putting a grommet, you will put it in the anterior inferior quadrant because there's no important structure and grommet is a little long. Posteriorly, still the incus, stapes all go posteriorly. You have a chance of dislocating the bones. So that's why when you are doing grommet, it is in the anterior inferior quadrant, and when you're doing myringotomy, it is in the posterior quadrant. So guys, I hope this was useful for you. I know a lot of ENT questions for a change in FMGE compared to a lot of other exams. We are doing a lot of tests, mock tests for you. So please make sure that you are thorough with your PYQs and you take these mock tests, make a note of these and do it. No point taking my notes. मेरा handwriting इतना खराब है, अगर तुम pharmacist को भी दोगे वो तुमको कोई ना कोई दवाई पकड़ा देगा. But I'm sure that you can always revisit and watch this video or take important screenshots and be done with it. All right. Thank you guys. बहुत सारे questions थे तो comedy थोड़ा कम किया, but sometime when opportunity मिलेगी थोड़ा comedy भी करेंगे. Anyway, while doing medicine, we all eventually become a joke sometime or the other. Take care. Good night. Please, once this lecture ends, do leave some comments or questions that you have in the comment section once the live stream is done. And if there are any questions that I've missed out, I'll be happy to answer it, whether about life, philosophy, or ENT. Take care.